We all know this case who, in spite of bilateral uterine artery ligation, was still bleeding, and then we took decision of an unilateral internal iliac artery ligation. Now we know even by doing internal iliac artery ligation on one side, the effective reduction in pulse pressure is about 40 to 45%, which is good enough to prevent or minimize the pelvic blood loss, still maintaining some amount of the arterial flow. So here we are isolating the internal iliac artery. You can see the lumbosacral trunk below the lumbosacral trunk of the nerves below the internal iliac artery. Look how the mixture is moving. It is moving parallel to the internal iliac artery and dissecting the fibrofatty tissue associated with the trunk. So by gradual from lateral to medial and medial to lateral dissection, we are carefully separating the internal iliac artery, and that's how the trunk is completely separated or completely lifted. The suture is now being carried away with using a Maryland. This is a 0 number vicryl and it is slowly passed below the internal iliac artery. Mind you, we always require a right port here to tap the lateral pelvic wall, but I was not putting that right lateral port here because it was more of a demonstration surgery. The suture is now passed below the iliac artery and now is pulled up. If the lateral tissue is retracted by the right port, this job will become still easy. We are forming a knot. The importance is how you put this knot over the internal iliac artery. So we are not pulling on the threads, but the knot is gradually pushed into the pelvis or over the internal iliac artery. So we are removing the twist and see how the knot is being slowly positioned well. Never be in a hurry to pull over the suture because vicryl is notorious. It will cut across the vessel. So slowly we are going in and putting slowly. So you are going to slowly tighten the knot and that's it. So you can give it one more tug and it will close the lumen, forming the second knot and placing it again. Same principle, don't pull on the threads, but threads are being pulled laterally so that the knot goes and sits over the previous knot carefully and the knot will be cut. This is laparoscopic internal iliac artery ligation. Internal iliac artery supplies almost 80 to 90% of the blood to the uterus, and therefore internal iliac artery ligation is an important way of arresting pelvic hemorrhage. The artery may be ligated using the sutures as I have demonstrated. It can also be closed by applying clips, but I have some personal reservations about using clips because if there is inadvertently more pressure applied by the clip applicator, the clip may cut through the vessel leading to a torrential bleed. Therefore, clips should be reserved in the hands of experts only. You can also put shoelace tie, and that is that tie which can be removed at the end of the surgery. However, this will depend upon for what reason you are trying to ligate the internal iliac artery. If you want it for only temporary purpose, yes, you can always use the shoelace technique. But if you want in permanent closure, then we have to use either the suture or the clip. Laparoscopic internal iliac artery ligation is no way superior to open ligation, which is much faster, has got good access, and therefore laparoscopy should be only approached or only attempted when the situation is under control. This is very important because the first principle of any good surgery is to do no harm.